Good afternoon, and welcome to the Society for Academic Emergency Medicine's National Grand Rounds. I am Dr. Jim Holmes, President of SAEM. For those of you joining us for the first time, SAEM is the premier international organization representing researchers, educators, and academic leaders in emergency medicine. In our work, SAEM promotes and facilitates scientific discovery, educational innovation, and the professional and leadership development of our members. Today, we are bringing together emergency physicians from all over the country and the world to hear from Dr. Anthony Fauci about vaccine distribution and what it means for emergency medicine. We are grateful to Dr. Fauci for taking the time to share his knowledge, expertise, and experience with the larger emergency medicine community. After the Grand Rounds presentation, our moderators, whom I will introduce shortly, will facilitate a question and answer session between Dr. Fauci and our content experts. I would like to thank the co-sponsors of today's events. We have all of the emergency medicine organizations joining us today. I would also like to thank our content experts and all of the viewers joining us on Zoom, Facebook, and YouTube. Finally, I would like to thank our moderators for today, Dr. Ian Martin and Dr. Rich Rothman, who will be guiding our discussion. Dr. Ian Martin is professor with tenure of emergency medicine and internal medicine at the Medical College of Wisconsin School of Medicine in Milwaukee. At MCW, he serves as system chairman of the Department of Emergency Medicine, as well as emergency physician-in-chief in the Freighter and Medical College of Wisconsin Health System. Dr. Martin is the immediate past president of SAEM. Dr. Rich Rothman is professor of emergency medicine and internal medicine at Johns Hopkins University School of Medicine. Dr. Rothman serves as executive vice chair in the Department of Emergency Medicine and has chaired the SAEM COVID-19 education team. Dr. Martin and Dr. Rothman, thank you for being here today and for moderating this important discussion with our special guests. Dr. Rothman, I now invite you to introduce our guest and speaker, Dr. Anthony Fauci.
Thank you, Dr. Holmes. To better understand the evolving role of vaccines in the ongoing pandemic, we're privileged to be joined by Dr. Anthony Fauci. Dr. Fauci, as everybody knows, is the National Institute of Allergy and Infectious Diseases chief, and he's at the National Institute of Health, where he's served for more than 40 years, where he oversees a broad research portfolio there focused on infectious diseases and immune-mediated diseases. Dr. Fauci is also widely recognized as one of the world's most productive and cited biomedical scientists, helping to characterize basic aspects of HIV, pathogenesis, and develop effective treatments for people infected with HIV. Dr. Fauci has previously advised 6 past presidents on various domestic and global health issues. He was one of the principal architects of the President's Emergency Plan for AIDS Relief, PEPFAR, which saved literally millions of lives throughout the developing world. He's also championed both basic and applied research to address emerging infectious disease threats, including the US and global response to H1N1 and the Ebola pandemic. Throughout the COVID pandemic, as noted by CEO of the American Medical Association, Dr. Fauci has been the consistent voice of fact and reason based on the best evidence at the time. We're extremely appreciative that he will now continue to serve in a central role as President Biden's chief medical officer. Dr. Fauci has consistently recognized and supported the role of academic emergency medicine investigators as critical scientific partners to address emerging infectious disease threats. He's also been highly supportive of the critical role emergency clinicians play at the front lines throughout this pandemic. We look forward to hearing your perspectives and updates, Dr. Fauci, particularly on development and challenges around the rollout of vaccines. Welcome, Dr. Fauci, and thank you for joining us.
Thank you very much, Dr. Rothman. I appreciate the opportunity to be with you today. What I thought would be helpful would to me to go very rapidly through some broad general slides to set the stage, the latter part of which will be associated with vaccines, and then to leave some time at the end to be able to answer questions either on the arena of vaccines or on any other aspect of what I mentioned during the presentation. So, some of you may have read about a year ago, I gave a viewpoint to the Journal of the American Medical Association. And when the first case, remember, the first case was in the United States, was recognized in January the 21st of 2020. And I wrote this article. I didn't mean to be at all facetious, and I entitled it Coronavirus Infections More Than Just the Common Cold. And the reason I did that, I wanted the readers of the Viewpoint to realize that we've had considerable experience with coronaviruses over decades and decades, which ultimately really has an implication with regard to vaccine. If you look at the phylogenetic tree of coronaviruses, the human coronaviruses are in red font, but 4 of them in yellow highlight account for about 15 to 30% of all the common colds that all of us experience repetitively each year, usually during the winter months. Then in 2002 and 2012, we had our experience with the first pandemic coronaviruses, which we now know we're quite familiar with. The first was SARS in 2002 to 2003. That with SARS was an outbreak that jumped species from bats to civet cats to humans. It was not particularly efficient in being transmitted from human to human. And so public health measures alone essentially eliminated it. 10 years later came the Middle East Respiratory Syndrome in 2012, again from a bat to a camel to a human, never really developed the pandemic proportions globally, and still is somewhat smoldering in the Middle East, particularly Saudi Arabia. Fast forward to where we are right now, a little more than a year ago, this month in January, there was an outbreak of an unusual pulmonary disease in the Wuhan district of China, which on the 9th or 10th of January was recognized as a new strain of coronavirus, which when you go back to the phylogenetic tree, what you see is that, in fact, it is remarkably close to the SARS coronavirus that was first recognized in 2002. So the nomenclature changed. The original one became SARS-CoV-1, and this became SARS-CoV-2. And in fact, the disease, as you know, is referred to as COVID-19 or coronavirus disease 2019 because the first clinical cases were recognized in 2019. Now it's happened, this has exploded into a historic pandemic, the likes of which we have not seen in 102 years. As of yesterday, over 100 million cases, over 2 million deaths. Unfortunately for us, we in the United States were hit worse than any other country in the world for a variety of reasons. Now, as of yesterday, with 25 million cases and 423 plus thousand deaths in the United States, with a projection that by the end of next month, we may close to 500,000 deaths. If you look at the surges that we've experienced, the early spring surge dominated by the New York City metropolitan area, then we try to open the country and open the economy in the early summer, another surge. And what we're in now is the late fall, early winter, which was really triggered by people coming indoors more than out and having holiday seasons such as Thanksgiving, Christmas, New Year's, and congregating indoors for those reasons. The number of hospitalizations have stressed our system. I don't need to tell the listeners of this particular talk how that is indeed the case. Unlike any other challenge we've had before, where there have been record number of hospitalizations, and in some areas of the country where you have intensive care units, where you have 20 beds and maybe 40 to 50 people are there needing intensive care. This, as you would imagine, leads to an increase in deaths as shown here, and the deaths are continuing anywhere from 2 to 3 to 4,000 per day. We've never seen a situation such as this. And again, this is just some of the newspapers of Fort Worth, Texas, and Los Angeles Times showing the extraordinary situation regarding deaths. Very quickly, just alluding what I said before, virology, this is an RNA virus. RNA viruses like to mutate. This is going to have a lot to do with the variants that I'm sure we'll discuss in the question period, but also has impact on vaccines. The structural protein that is the spike protein that binds to the ACE2 receptor is the backbone of virtually all of the vaccines that are currently being tested right now. Getting to variants, we now have the clear, as you'd expect, evolution of various lineages. In the UK, and that virus is now in the United States in over 300 cases, in now most recently 28 states. I'll talk a little bit later in the question period about the real and potential impact this might have on vaccines. We are quite concerned about the South Africa lineage, the 351, for the simple reason that by in vitro neutralization, it diminishes by multiple fold the efficacies of the antibodies in vitro. Currently ongoing clinical trials that have elements in the United States, in UK, as well as in South Africa, will tell us from a practical standpoint what impact this is going to have on the efficacy of existing vaccines. Transmission, you all know about respiratory droplets. I won't waste much time on that. You know of the things that we are talking about now for months, about the universal wearing of masks, physical distance, avoiding crowds, doing things outdoors better than indoors. We know a very unusual aspect of this, that there is a significant proportion of people who are asymptomatic. Available data suggests that at least 1/3 of the infections never develop symptoms, and maybe 10% or more are asymptomatic at the time that they are transmitting. This recent paper from the JAMA Network showed that 35% of transmissions occur from a pre-symptomatic person and 24% from people who never develop symptoms. You're all familiar with the clinical manifestations presenting like a typical flu-like syndrome, but then can go on in some individuals very rapidly. An unusual loss of smell and taste seen in a substantial proportion of individuals. Now, I mentioned that maybe about 40% of cases have no symptoms. Of those that do have symptoms, about 81% are mild to moderate, about 20% are serious, leading to case fatality rates that go anywhere from a couple of percent to up to 20-25% of people who require mechanical ventilation. The manifestations of severe COVID-19 are protean, acute respiratory distress being one of the prominent ones, but also cardiac, neurologic, kidney, hypercoagulability, and in children, a multisystem inflammatory syndrome. Older adults clearly have a much greater propensity to serious disease, as shown by this hospitalization ranked by age of the patient. But also people of any age with underlying medical conditions, they're shown here. You're all familiar with them. I won't spend much time on them. The one thing I do want to point out, particularly here in our own country, is the extraordinary disparity among brown and black people who, if you look at the hospitalization per 100,000, you're dealing with a considerable disparity between Latinx, African Americans, Native Americans, and Alaskan Natives compared to whites. We have an interesting post-acute COVID-19 syndrome, which we're actively studying, which individuals have for variable periods of time, considerable persistence of fatigue, weakness, muscle ache, sleep difficulties, as well as what they're calling brain fog, namely an inability to concentrate. Again, very rapidly, therapeutics. There are a number of interventions that now have been given an emergency use authorization. The FDA has approved remdesivir, but if you look at monoclonal antibodies, convalescent plasma, and others, what we really need is a intervention that can be given orally early on to prevent people from having to go to the hospital. The one interesting thing that the British showed in a study about mortality, that dexamethasone in individuals who are hospitalized on ventilators or requiring high flow oxygen diminishes significantly the 28-day mortality. US NIH-led panel on treatment guidelines is available for people who actually are looking for the up-to-date data, either from published data or clinical trial data that has not yet been published. So let me just stop in this very quick 10-minute presentation and tell a little bit about vaccines and then open it up for questions. The United States government took a strategic approach to vaccine. Namely, we are supporting the development or facilitating the testing of 6 separate vaccines that are 3 separate platforms with 6 companies shown here. The one that you're all familiar with is the nucleic acid, which was essentially the phase 2-3 trials of Moderna as well as Pfizer. Very soon, in the next couple of days, you'll be hearing about data from Janssen and Novavax, and I think we just need to pay attention to that. The highly successful vaccine, more than we even expected. We're 94% protection in the mRNA of Moderna and 95%, no difference there with the Pfizer product. Both of these now have emergency use authorization. It is being widely distributed throughout the country, and the safety profile seems to be really quite good. Vaccine distribution, you know, the Advisory Committee on Immunization Practices has given the various phases: healthcare personnel, long-term care facility, followed in 1B by frontline essential workers, elderly individuals, and then as we get into 1C, people 65 years of age or older, and younger people with high-risk conditions. There is now contractual arrangements made to Pfizer and to Moderna to get even more vaccine than we originally contracted for. I want to end by talking a little bit, just for a moment, about the fact that if we want to get what we call herd immunity, that likely will be about 70 to 85% of the people vaccinated. But we know among particular groups, particularly the demographic group of minorities, have a great deal of hesitancy. So it's our responsibility to reach out to them and to try and get them to actually get involved in taking the vaccine by proving, which we did with the trial, that it was safe and effective. Just want to close by showing that in the spirit of getting people to accept the vaccine, President Biden and Vice President Kamala Harris did it publicly. I myself did, shown here. I'm in the middle panel together with the Secretary of HHS and NIH Director Francis Collins, to getting the vaccine to show to people that it is in fact safe, and we know from the trial that it's effective. One final thing, we got to remember that even when we get vaccinated, the fact that you might still have virus in the nasopharynx, we still recommend that you continue to use masks as opposed to putting aside all kind of public health measures. Stop there and happy to answer any questions. Thank you.
Thank you very much, Dr. Fauci, for this timely and insightful presentation. Audience members submitted hundreds of questions in advance of the session today. Our content experts have prioritized these questions. We will try to get as many as possible in our remaining time. Dr. Martin, would you like to ask the first question?
Be honored to, Dr. Holmes. Thanks for joining us, Dr. Fauci. It's terrific to meet you. So with the successful leveraging of HIV and hepatitis C testing programs to increase detection and care linkage of infected individuals, many emergency departments are also looking to vaccinate willing patients against COVID-19. What are your thoughts on emergency department-based COVID-19 vaccinations, and how can emergency medicine clinicians combat vaccine hesitancy in reluctant patients, particularly patients of color, in our emergency departments?
Well, let me start off, Dr. Martin, with your last question first. And I think one of the things that I have learned through the years, not only with COVID, but with other interventions where you want to get brown and black people involved, be it an HIV trial, an influenza trial, or what have you, we have to respect the hesitancy that brown and black people have, because the history, although it was decades ago, going back to the infamous Tuskegee issue, is there. We can't run away from it. So we've got to respect that they're hesitant, but then go in a step-by-step way to try and explain, why is it that you're hesitant? Do you believe it was done too quickly? It is. I mean, it was extraordinary. We went from the sequence of a virus to getting a highly effective vaccine in the arms of people in about 11 months. A decade ago, that's would have taken 7 years. But that is not a reflection of cutting corners. That's a reflection of the application of exquisite advances in the science of vaccine platform technology. So we got to get that off the table. The next thing is it really safe and effective? And maybe it'll take a minute to explain that the trials involved 30,000 and 44,000 people. There was good representation from brown and black people. A total of about 36 or 38% of them were individuals of minority groups. And it was shown to be safe and effective with them. And the decision about whether it was safe and effective was not made by a government political appointee. It was made by an independent data and safety monitoring board, which then gave the data to the company which presented it to the FDA. And in fact, they used their own advisory committee to make the decision it's time to distribute it. So that's the answer to your second question. The first question is, you have access to people. And I think by the time we get to go through those priority groups, anytime somebody comes in through the emergency room for any reason, if you have the supply, you should really seriously consider getting vaccine for this particular disease. In fact, I would think that you as a group of a subspecialty of medicine may be a better positioned than almost anybody, because people are coming in to you, they're relying on you, you're fixing their problem, hopefully right there. And you say, by the way, there's another real threat to your health and it's out there, so you want to get vaccinated. I think it'd be a great way to distribute vaccines.
Thank you, Dr. Fauci.
So just picking up on a point that you made about some of the drift variants, this question comes from Ailey Klein from Hopkins. He asked, given the appearance of some of the antigenic drift variants from Brazil and South America, how are we currently tracking drift variants in the United States, and how quickly can some of the companies pivot and update vaccines to respond?
Okay, so the UK, we try not to call it a UK variant because that's stigma, but the 117, which is dominant in the UK, is also here in the United States. It's about 28 states have about 400, so it's already here. The South African one, unfortunately, is also here. There was a case in Minnesota, and yes, yesterday and last night, another case in, I believe, South Carolina was reported. Our surveillance, genomic surveillance system, right now and last month and the month before was not what it really should have been. So right now, we're scrambling, the CDC together with the NIH, to get a more comprehensive interdigitating genomic surveillance system so that we can actually get a handle about what these are. The second part of the question is, we are already, together with the pharmaceutical companies, making versions, for example, of the mRNA that instead of having the insert expressing the wild type spike is expressing the spike, which is called a 501YV2, which is the South African mutant. So we're already there, and we're going to be doing phase 1 studies soon to determine the safety and immunogenicity. I don't think you're going to have to do a complete multi-thousand person trial to get it approved. You could probably use it as a strain change the way we do with influenza each year.
So Dr. Fauci, we had a number of participants who submitted questions related to the following. So what is the plan and timeline for COVID-19 vaccine trials in children under age 12 years? And do we need to vaccinate younger children to achieve herd immunity?
Well, answer to the second question, it would be important, yes, to include children in that group. I mean, you could say it may not be necessary because children do very, very well. They don't seem to spread it in the context of school, even though when you do have serious outbreaks, children are involved. So you would like to vaccinate as many children as you can. What we're doing is we're doing a very commonly used age de-escalation trials where you go from 12 down and then from 9 down and then from 5 down. They are starting imminently, literally at the end of this month, and we only have 3 more days in the month. And as we get into February, we're going to be starting those trials. Again, you don't need thousands of people in those trials. You just got to get safety and immunogenicity to do a bridge study. Hopefully, by the end of the next several months, we'll have enough data to get children into the trials for efficacy. I said into the trials, I mean actually approved for children, not in a trial.
You mentioned the role emergency departments may be able to play in vaccination. Can you just speak broadly to research efforts that the emergency department can contribute to going forward in terms of collaborating with infectious disease and critical care colleagues?
Oh yeah, I actually I'm glad you asked that. So we have interventions that are only really effective if given really early in the course of a disease, such as convalescent plasma, which if you give it after a person has already developed their own antibodies, it has much less of a positive effect. In fact, maybe even no effect. The same holds true for monoclonal antibodies. So if you're going to test early in the course of disease, you want to get somebody that comes right into the emergency room, looks like they're beginning in the early phase of acute COVID, and get them right into a study. So you should partner with the clinical researchers in your institution to see if, in fact, you can have an emergency medicine, Department of General Medicine collaboration on trials of things that need to be given as an outpatient early in the course of disease. Emergency medicine is the best possible place to do that.
Thanks. There's a lot of efforts going on in that regard already, so we're happy to hear that.
Right.
So Dr. Fauci, the following question comes from Dr. Milan Djokovic, who's with Brevard Physician Associates, and he asks, with what we've learned about COVID-19 pandemic, what should we be doing in the future to better detect novel viruses sooner?
Well, that's going to be the subject of, I hope, some really serious postmortems when this is over. One of the things that jumps out at us is the weakness of our local public health capability. We didn't realize that until it just hit us right between the eyes. You know, we had, back at the time when we had a lot of TB and a lot of sexually transmitted disease, and the local health departments were very active in doing that. Then we had good treatments and vaccines and things like that. And the local public health departments were left to really decline a fair amount. We've got to start putting some serious money into that so that the next time something like that happens and gets us locally, we have good communication, good surveillance. You could do good identification, isolation, and contact tracing. You can extrapolate that to the rest of the world. And that's the reason why, in one of the things that the President Biden has just said in his plan, is to really strengthen the global health security network, where you have surveillance and communication throughout the world, not only just in our own country. So there's a lot that we're going to be doing regarding lessons learned.
Dr. Rothman?
Dr. Rothman?
Yeah, sorry. So can you speak at all about studies being done to better understand transmission in asymptomatic, vaccinated individuals? What's the status on that, and how is that going to affect policy?
Yeah. So the situation that we have that Dr. Rothman, I believe, is referring to is that the primary endpoints of the Moderna and the Pfizer trial was clinically apparent disease as a primary endpoint, and severe advanced disease is a secondary endpoint. What you don't know yet, but we will know as we follow people within a year or two, is whether a person who is prevented because of the vaccine prevention gets infected but doesn't get symptoms and doesn't know it. So the real question is, if that's true, is that person able to spread the infection to someone else? And does the vaccine really prevent the spread of infection, or does it just individually prevent somebody from getting sick? We would like it to be both. So one of the studies that's going to be done, and it's actually already started and planned, is to follow people who are vaccinated and asymptomatic compared to the other group of a large number of people who are not vaccinated and get asymptomatic infection, and do comparison quantitation of viral load in the nasopharynx, and find out if the mean nasal pharynx viral load is substantially less in people who are vaccinated. And you could do cycle thresholds in there and find out that if you're vaccinated, you may get infected, but your cycle threshold is 34 or 35 or 36, which means the chances of your transmitting it to somebody else are almost zero. So that's the kind of study that's being done.
Thank you. So the next question comes courtesy of Dr. David Talon at UCLA. He asks, what do you see as the similarities and differences between the COVID-19 pandemic and other major recent viral illnesses that have had far-reaching effects such as HIV?
That's the most commonly asked question, because in our lifetime, the two that have phenomenal global impacts are HIV, which has 77 million people infected total, and about 30 some odd million have already died. That's spread over, it'll be 40 years. It was actually 40 years this summer when it was first recognized in 1981. The difference here is that truncated within a year, you had the most explosive respiratory illness that we've ever seen. So one is a respiratory illness that essentially threatens every single person on the globe, whereas HIV is a very serious disease, but as you know, it is much more prevalent in certain subgroups, particularly in the United States. I mean, the disparity among men who have sex with men, particularly African-American men who have sex with men, and the risk to the other demographic groups, with some exceptions, is really very, very low. The one thing that's the similarity is that outbreaks and pandemics have always occurred. They're occurring now, and we, as physicians and healthcare providers, we've seen two major ones in our lifetime. And in fact, there are going to be others beyond our lifetime. So it just underscores the fact that outbreaks occur. And you're not going to prevent new emergence of infection. But what we can do with preparedness is prevent those outbreaks from becoming global pandemics. And unfortunately, we were unsuccessful with both HIV and COVID-19.
Thank you. So it appears we have time for just one last question. So Dr. Fauci, you are a physician, you're a scientist, you're a leader, and you're a role model to so many. So how have you personally managed the stress of a once in 100 years pandemic?
Well, you know, it hasn't been easy, and I think there are a couple of things that I believe, and though I can't really fully analyze it because I'm drinking from 2 fire hydrants every single day, and that is you just focus on the enormity of the problem and the responsibility that you have. So you can't get distracted by anything else other than what the goal is. And for me, the goal is to end this outbreak through science and public health. And that's what I concentrate on every day. And it is exhausting. I mean, I don't mean to fool you. It is really exhausting. You know, I joke with people, and I think the people in this audience would understand, particularly the more older of you, is that when I was an intern, a senior resident, a junior resident, a chief resident in medicine at the New York Hospital Cornell Medical Center at the time, we were on every other night and every other weekend. So you learn to really suck it up and just go there and do it. So when I describe to my physician friends, it's like kind of your internship times about 10. So if you've been through a medical internship or a surgical internship or whatever, it really gives you a good head start. So that and the purpose of what I'm doing gets me through it.
Well, your response makes me think you probably would have been a fantastic emergency physician as well. Thank you for your discussion today. Thank you for taking so many of our questions. Dr. Holmes, I'm going to turn it back over to you.
Yeah, thanks, Dr. Martin.
Thank you again to Dr. Fauci for sharing your expertise with the academic emergency medicine community across the nation and around the world. I would like to personally invite you on behalf of SAEM to our next in-person annual meeting, which we hope will be in New Orleans in May of 2022.
Great.
Thank you again to Drs. Martin and Dr. Rothman for their time today, and to all of the content experts, co-sponsors, and viewers for joining us for this special presentation. And thank you all to all the dedicated emergency care providers for your heroism and bravery as we fight this pandemic together. Stay safe and have a good day.